morning and welcome back to Open Med School. In the last session, we have discussed about the approach to a patient with cardiac disease, the method of taking history, and what are the important points in history. Today, we will be discussing the major symptoms of cardiac disease, that is, symptoms of cardiac disorders. We look into the pathology and identify what are the symptoms. So I will divide the symptomatology into symptoms due to heart failure, because the primary function of heart is to act as a pump, and when the pump fails, what happens? What are the symptoms? Second, the heart is supplied by the coronary arteries, and when the arteries are insufficient in supplying blood to the heart, what will happen? That is ischemic symptoms. Third, the heart has got a rhythm, that is the rate, and changes in the rate and rhythm, what will happen? And rarely symptoms can be due to compression of an enlarged cardiac chamber or an arch vessel on other intrathoracic structures, and some symptoms are preferentially seen in congenital heart disease. The last will be discussed at another session. So we divide the symptoms into symptoms of heart failure, that is low cardiac output, and systemic vein or venous congestion, systemic and pulmonary venous congestion. Ischemia is clear, and changes in rhythm and compression of the cardiac intrathoracic structures. So we'll take one by one. Number one is symptoms due to pump failure. When the heart is failing as a pump, the cardinal symptom is dyspnea. The mechanism of dyspnea I have explained earlier, so just briefly I will mention that when the heart fails as a pump, the heart is unable to pump the blood, what will happen? The chambers behind that, there will be congestion. For example, when the left ventricle fails as a pump, what will happen? The left ventricular end diastolic volume and pressure will increase. This will be transferred to the left atrium, and this will be transferred from the left atrium into the pulmonary veins, because pulmonary veins are connected to the left atrium. So left ventricle fails, the changes in the pressure that is occurring will be transmitted to the chambers behind it. Here it is left atrium followed by pulmonary veins, and finally what happens in the pulmonary system, the venous end of the capillary, the pressure is increasing. So what the fluid will translate in the lung. So there is the interstitial edema followed by pulmonary edema. So the major symptoms of dyspnea is an indication. If it is due to cardiac disease, it means pulmonary venous hypertension, not arterial hypertension, it is pulmonary venous hypertension producing pulmonary congestion. This can be a gradual one that is occurring during exertion, or it can occur abruptly as pulmonary edema. So this may present with cough and hemoptysis, and as the lung is congested, you can get recurrent lung infections. So remember the major symptom pump failure, that is, and the symptom due to lung congestion, and this is part of the left ventricular failure. So you get these are the symptoms. Please refer to the chapter on dyspnea to know more details. Now we go to the next symptom, that is or you can just I will briefly describe what happens when so you can get pulmonary pressure, venous pressure increases. We can get paroxysmal nocturnal dyspnea. Can be pulmonary congestion that leads on to cough. Examination show various findings like crackles, wheezes, blood tinge, frothy sputum, increase rate. So patient can have the restlessness, confusion, orthopnea, tachycardia, fatigue, and sinuses. So these are the symptoms. Remember, left heart failure leads on to symptoms of pulmonary congestion. This leads on to decreased oxygenation, and finally this leads on to the symptoms and signs that I have briefly discussed. Now we go to the symptoms due to low cardiac output. That is, when the heart is left ventricle is failing, it will lead on to decreased cardiac output. So first we have mentioned about the symptoms due to pulmonary congestion. So now what will happen? There will be tissue hypoxia. It can affect the brain, confusion, muscles, fatigue, kidneys, renal failure. Hope this point is clear. You can get the exertional dizziness, syncope, oliguria, angina. So when the heart fails as a pump, blood supply to the coronary artery also comes down, so it can precipitate angina also. So the next symptom is symptom due to systemic venous congestion. That is, it is a right heart failure. We have mentioned that when the left ventricle fails, the lung gets congested. But left ventricular failure can lead on to right heart failure, or right heart can per se fail. During that time, what happens? Just like that of the left ventricle, there is venous congestion occurring in the, so the right ventricular failure, the right atrium fails. In the right atrium fails, what happens? The venous systemic venous congestion occurs. The liver is connected to the inferior vena cava by the hepatic veins, the legs. So what will you get? You get a congestion behind, or all the other parts behind the failing chamber, pressure increases. This leads on to, when the liver is congested, you get the pain in the right hypochondrium, loss appetite, dyspepsia. And the lower limb, the venous system, just like the pulmonary edema, you can get a pedal edema. So there will be swelling of the lower limbs. There can be fluid in the abdomen, ascites, and when there can be decreased renal perfusion due to the heart failure, can lead on to oliguria. The main symptoms due to systemic venous congestion in right heart failure, you should remember, one is the pedal edema and right hypochondrial pain, dyspepsia. Three cardinal signs you should remember. One is elevated JVP, tender hepatomegaly, and pedal edema. The first symptom or sign to appear, not symptom, the first sign to appear is the JVP, and the last sign to disappear is also JVP. So when somebody has got a pedal edema and JVP is not elevated, that's the point to remember. Somebody has got pedal edema, but the JVP is not elevated, it is not due to heart failure, because I already mentioned the first sign of heart failure is elevated JVP, and the last sign to disappear is also JVP. Now we will quickly look into what are the findings that you get in right heart failure. As mentioned, because of the liver congestion, loss and abdominal discomfort will be the loss of appetite, tenderness or pain in the right hypochondrium, lower limb edema, and weight gain, fluid retention. As mentioned, the left heart failure leads on to mainly shortness of breath. So breath dyspnea is the classical finding that you get in left heart failure. You can get in addition palpitations, fatigue and tiredness, and other tissue hypoxia symptoms. Whereas in right heart failure, you get predominantly pedal edema, weight gain, right hypochondrial discomfort. Hope this point is clear to you. So many times these symptoms can occur in the same patient. All the symptoms are due to congestion, and we call the patient is having congestive heart failure. So the first pathomechanism, the pathophysiology of symptoms in heart failure, dyspnea and pedal edema and tissue hypoxia, we have discussed. Now we go to the second symptom, that is symptom due to ischemia, that is coronary blood supply is decreased. The classical pain, the pain that occurs is the angina pectoris. There are different types of angina that we will study later depending upon the duration, onset. But in addition, the pain in cardiac disease can occur due to dissection of aorta or aortic aneurysm. Pericarditis can produce. So that you remember, this is chest pain in cardiac disease is not only due to angina, it can be due to pericarditis, it can be due to dissecting aneurysm, or it can be due to some aortic aneurysm also. Again, remember, chest pain can occur due to chest wall problems, mediastinal problems, diaphragmatic problems, and abdominal problems, or the gastrointestinal problem like esophagus or gastritis, reflux gastritis. So a systematic approach to chest pain will be discussed later. We are concerned with the anginal pain only at this time. And the classical angina usually lasts to 5 to 7 minutes, and patient may show the hand like this. This is called the Levin sign, the size of a fist. If the pain lasts more than 30 minutes, you call it as myocardial infarction. More likely, the pain is consistent with the myocardial infarction. And again, we have to describe the symptoms. We have mentioned each symptom has to be analyzed on OPQRSTA format. Please refer to the chapter on elicitation of history in chest pain. So this is general format that you should follow. Then coronary disease, you should again remember that many patients don't have the classical textbook description of symptoms. So some patients may come only with the epigastric discomfort. So remember the atypical presentation. So sometimes they will be presenting just like with breathlessness. It is called coronary equivalent. Should not miss dissection. In dissection, the pain is maximum in the beginning. It is like the pain is like a shearing pain. So if in the coronary disease, if we take the pain comes like this and goes to the peak. In dissection, the pain is maximum in the beginning, and then it. So it is a tearing phase. It is a tearing pain, and it is referred to the back interscapular region. And again, remember all patients with myocardial infarction need not have ECG changes also. So history is very important. So hope you got the point. Now we go to the third pathophysiology. It is a change in the rhythm, rate and rhythm. So this arrhythmias can produce. We should go into the details of time, mode of onset to offset, relation to exertion, duration, irregularity, etc. Minimum thing you should ask whether it is a fast one. Ask the patient to tap on the thigh or tap on the table like this. So it will be an exact replica of the palpitation. You can approximately identify the rate. If it is whether it is a slow like this, whether it is a rapid like this, whether it is rapid and irregular like this, or occasional thudding like this. So even the rhythm can be to some extent identified. You should identify what is the onset, what is the offset, whether it is rapid onset as in paroxysmal supraventricular tachycardia and a rapid offset. And the details will be discussed again. This palpitation can lead on to syncope, or it can lead on to other symptoms, chest pain, etc. So lightheadedness, sometimes the patient may not come and tell that they have got palpitation. They may only say, I have got lightheadedness, a feeling dizzy, chest pain. And whenever the heart rate is more than 100, it is called tachycardia. And you should ask about a family history of heart disease also in such patients, just like in any cardiac symptoms. So now we go to the next mechanism of symptoms, that is compression of other structures. The pulmonary artery or the left atrium can compress on the recurrent laryngeal nerve on the left side. This can lead on to the recurrent laryngeal nerve may be compressed, and the patient may complain of hoarseness of voice. If it is compressing the esophagus, it can produce dysphagia. Compression of the left recurrent laryngeal nerve, especially in mitral stenosis, this is called a Orthopnea syndrome. So ask about dysphagia can be seen in my patients with the mitral stenosis when the pulmonary artery or the left atrium compresses the left recurrent laryngeal nerve. So today we have discussed about the basis of the cardiac symptomatology. So I will divide the symptoms due to left heart failure, to right heart failure, due to changes in the rhythm, and also due to compression on the adjacent structures. Symptoms peculiar to congenital heart disease like tetralogy of Fallot will be discussed in another session. Hope it was useful to you. Thank you.